Pilocytic astrocytoma, yes, but it can occur in adults also, not specifically for pediatric. Any tumor can occur in the pediatric age group. So we can name actually anything. That doesn't matter, but specifically some tumors arise in the pediatric age group which are specific for pediatric age groups. And today we will be discussing only those tumors. Okay. So benign tumors, we'll be discussing any tumor can occur. So let's just ignore that. Mainly we'll be discussing hemangiomas, fibrous tumors and teratomas. These are important for pediatric age groups because they are more common in the pediatric age group. Among the malignant tumors, CNS, there can be medulloblastoma. It is specific for pediatric age group. Okay, these are embryonal carcinomas which follow an embryonal morphology. So then that's medulloblastoma. Apart from that, neuroblastoma, which occurs from the sympathetic chain. Where is the sympathetic chain located? Beside the vertebrae, right? Yes. So if it occurs from the sympathetic chain, it most commonly occurs from the sympathetic chain. Then that's neuroblastoma. Location most commonly in the abdomen. Apart from that, there can be retinoblastoma. You have all heard about retinoblastoma. You have read the Knudsen-Tuhet hypothesis, right? RB gene. RB gene is important for another carcinoma. Yes, another sarcoma which occurs in, not exactly pediatric, it occurs in adolescents and younger adults. Yes. It has actually bimodal age distribution, occurs in either elderly or younger adults, mainly males. Another tumor which has bimodal age distribution occurs in younger adults or elderly, skips the middle age group. Which tumor? Name it. You just said that. Hodgkin. CLL, whenever we suspect CLL, we will look at the age. If it is not elderly, we will try to rule out. So CLL, I'm not saying any tumor cannot happen in younger patients, but CLL is for older age group. Hodgkin. Hodgkin either occurs in adolescents or younger children or in the elderly. Okay. I will discuss the other tumors as well. Let me get into it. So name some common tumors. I've discussed this. Which are benign, which are malignant. I've discussed it. Name the most common cause of death among children in the world, first world countries, where the most research takes place. Actually, so that is why it reflects worldwide. That is because most research takes place in USA, UK. So we get their data more. So tell me the most common cause of death among children. Leukemia. In USA, it can be accidents. Previously, it was accidents, but now it is cancer because they are dominating, their medicine is dominating infectious disease. In our country or in third world countries, the most common cause of death is either infection or malnutrition. We all know that. Whenever we get a patient, we will always suspect TB. প্রথমে TB হয়েছে. If not TB, then something else, maybe. But in their countries, like in NHS, the most common cause of death is leukemia. So this is the next frontier for medicine actually. So hemangiomas, these are, today I will only be showing you pictures. You anyway don't listen, don't take notes, anything, you don't bother. I will be showing you pictures. So this is an example of hemangioma. Name the types of hemangioma. Can you name the types of hemangioma? Capillary hemangioma, cavernous hemangioma, right? It mostly it occurs as a congenital condition, like the baby will be born with a hemangioma. These babies, you can see, they are born with a hemangioma. My son was born with a hemangioma. So it is actually called a strawberry hemangiomas because it looks like a strawberry on the skin. It is very reddish and it's composed of small capillaries. Hemangiomas can occur in adults also, but in the pediatric age group, it is usually more cellular. The hemangiomas that we get in a pediatric age group is usually more cellular. Hemangiomas can be sporadic, can be syndromic. What is the difference between sporadic and syndromic? When I'm using these terms, you have to understand what I mean. তোমরা দুজন বলো, difference between sporadic and syndromic. You're exchanging something? Notes. Tell me the difference between sporadic and syndromic. What is meant by a syndrome? You can say, this is not an exam. You say whatever you feel like in an exam. So now, so you can say anything you want. You're not being marked. Yes, group of symptoms. So in a syndrome, there will be some specific genetic aberration or some specific chromosomal abnormality which gives rise to a group of symptoms involving different systems. That is usually a syndrome. And sporadic is that a person is not, it is also associated with a genetic mutation, but it is not a recurring genetic mutation, and it will not have a germline transmission. That is, from father to son and from mother to son or child, it will not be transmitted. Then that is sporadic. Like retinoblastoma, again I'm coming back to retinoblastoma. It can be syndromic, it can be sporadic, right? I will get into retinoblastoma today a little later. So these are examples of hemangioma. So name one syndrome associated with hemangioma. Specifically, cerebellar hemangioma. Have you heard? Have you heard of VHL? VHL, von Hippel-Lindau. This is important. This is important for MCQs. If you want to appear for a PG exam, this is a basic MCQ you have to know. Na janle to jeevone hobe na. Right. So VHL is located in chromosome 3p. It causes von Hippel-Lindau syndrome, which is associated with cerebellar cavernous hemangiomas and clear cell carcinomas of the kidney. Right. Some other symptoms are also associated with it, but these are the most common symptoms associated with VHL. Okay. So this is the cerebellar hemangioma that I was talking about. Now this is, some people call this a hemangioma, and some people call it a vascular ectasia. Ectasia means dilatation. So this is called a port wine stain. These are all examples of hemangiomas, right? Answer? Next, fibrous tumors. So fibrous tumors can be benign, can be malignant in children only. In pediatric age group, fibrous tumors can be benign, can be malignant. So the benign counterpart is called fibromatosis. You can see here, if you remember what are the features, usual features of a benign tumor, of a malignant tumor, this is a very good example. You can see a benign tumor. It is not hyperchromatic. Hyperchromatic মানে নীল নীল জায়গাটা কম, এখানে নীল নীল জায়গাটা বেশি. It has many nuclei. It has fewer nuclei, right? So this is a fibromatosis, and you can see the background is a bit fibrous. So this is a fibromatosis, and this is an infantile fibrosarcoma. Fibrosarcoma can occur in adults, can also occur in children. So this is an example of fibrosarcoma. Next, teratoma. Now teratoma, it mostly occurs in the pediatric age group. It has mostly a midline disposition. Meaning it will occur in the mediastinum, or like this is an example of sacrococcygeal teratoma. Right, a child will be born with this, and This is one of the most common teratomas in the pediatric age group. One in 20,000, I think, children are born with this, and sometimes they survive, sometimes they don't. And this can also be benign or malignant. Teratoma can also be benign or malignant. If it is malignant, then we have to look for some immature components within the teratoma, right? Teratoma, what happens is it contains tumors, contains proliferation of cells from all the three layers of the body, right? So it will have, say, keratin, or it will have some hair, it can have teeth, it can have bone, it can have glands, it can have neural tissue. But all of this will be mature teratoma. But if it may contain immature component, that means that, see, the neural tissue which is present within the teratoma, it is immature neural tissue. Only then we will say that this is an immature teratoma. But recently we have come to know that even if it contains some immature component, prognostically there is no difference. So surgeons, they don't bother if we say that it has an immature component or not. Surgeons, they don't care, because prognosis is more or less the same. It has more or less good prognosis. Actually, teratoma has good prognosis. Other areas where teratoma can arise is testis. In children, it is testis, and then ovaries, right? The teratoma that arises in the testis is worse than the one which arises in the ovary. In ovary, it is usually mature. In the testis, it will be mostly immature, because the germ cell which gives rise to the teratoma in the testis is more immature than the one which gives rise to teratoma in the ovary. Can I make you understand? Have you understood what I'm trying to say? The germ cell which gives rise to teratoma in the testis is more immature than the one which gives rise to teratoma in the ovary. Yes. The difference is that, like any immature cell will have more hyperchromasia, mitotic figures, embryonal component, that is anaplasia. That means there will be more nuclear pleomorphism or abnormal mitosis. Normally mitosis, this is what a normal mitosis looks like. Now, if the mitosis becomes tripolar, like a Y, or then it becomes abnormal mitosis. This is actually important for many tumors, and especially for pediatric age group tumors. We have to look for abnormal mitosis, abnormal mitotic figures, because it is prognostically very significant. We have to report whether or not we have seen any abnormal mitotic figures, because the survival of the child becomes very different. If there is normal mitosis, it is usually chemo responsive. If there is abnormal mitosis, it is usually not chemo responsive. So it is important that we look for the immature component. But again, as I said, in teratoma, the immature component does not make much of difference when it comes to prognosis. Whenever we report, we are thinking about prognosis, the 5-year survival of the child, right? So we have to think, what are the things I have to look for and what are important for this particular cancer, right? So this is an example of testicular teratoma. This is ovarian. You can see the hair. It has a Rokitansky sinus, all that. Now, teratoma can be associated with other germ cell tumor. Can you name any other germ cell tumors? This is an example of germ cell tumor. You will get into details of this in female reproductive and male reproductive when you go into your systemic pathology. But can you name any? Yolk sac tumor, have you heard of it? Yes. So teratoma can be associated with yolk sac tumor, and then it becomes more aggressive. Teratoma by itself is usually not that aggressive, and teratoma, either the child can be born with it, or it may arise like the child was actually born with the cancer, but it was very slowly growing, and the child will present at an older age, like say when the child is 10 to 12 years old, then the teratoma presents. That can also happen. Those are usually benign. And say the child already presents with a mass, like in this case, then it may be malignant, right? Next, malignant tumors. Now, whenever we have to diagnose a tumor, whenever we look at a tumor, we always look at the age, and we try to decide what it can be. We are looking at some pink background and some blue nuclei. Now we have to see what can it be, there are thousands and thousands of tumors that can occur. So when we see the age, now there is an age-wise predisposition for these tumors. Say for like leukemia, common in more, also in 0 to 4 years age or 5 to 9 years age, leukemia is common. Usually acute leukemias, right? Either ALL, mostly ALL, or maybe AML, but leukemias are common in both. Next, retinoblastoma. It is for 0 to 4 years age, retinoblastoma, neuroblastoma, Wilms, hepatoblastoma, soft tissue sarcoma, teratoma, CNS tumors mostly medulloblastoma. For 5 to 9 years age group, it is leukemia, neuroblastoma, hepatocellular carcinoma. The hepatoblastoma present in 0 to 4 years. If it presents at 5 to 9 years or 10 to 14 years or even older, it's usually hepatocellular carcinoma. Blastomas usually present in the infantile age group, 0 to 4 years age group, the blastoma is present. Soft tissue sarcoma, Ewing, CNS tumor, then again medulloblastoma, lymphomas. Lymphoma, most common Hodgkin lymphoma. 10 to 14 years, it becomes renal cell carcinoma, hepatocellular carcinoma, soft tissue sarcoma, Ewing, osteogenic sarcoma, osteosarcoma, and lymphoma. Now, in the pediatric age group, there are some specific characteristics of the malignant tumor. One of them is the blastemal component is present in the pediatric age group, like nephroblastoma. Other name for nephroblastoma is Wilms. It is important for your short notes also, and then again, you will get MCQs from Wilms. So, neuroblastoma, because they have a more blastemal, some embryonal cells or embryonal rests are present within the child, and then these give rise to cancer. Then it becomes a blastoma. Even rhabdomyosarcoma is that kind of, like rhabdomyosarcoma has 4 types. 2 types are common in children: embryonal rhabdomyosarcoma and alveolar rhabdomyosarcoma. These are common in children. Apart from that, nephroblastoma, hepatoblastoma, neuroblastoma, these. So, medulloblastoma. So, these tumors are usually more chemoresponsive or radiosensitive. They are more amenable to therapy, and they can even show spontaneous regression. Naturally, the tumor goes away from the body without treatment. That can also happen. And also, I forgot to tell you, for capillary hemangioma, it is very important for capillary hemangiomas. They can increase in size with age, but mostly they spontaneously regress. For strawberry hemangioma, this you will learn as a short note in surgery also. It's very important, strawberry hemangioma. A child presents with strawberry hemangioma, the mother is very worried, what is this in my child's body? But after say 2 years, it spontaneously regresses, and the whole area just has some few fibrous tissue, maybe like a scar, but no hemangioma will be present. It spontaneously regresses. And even some carcinomas, some blastomas in pediatric age group can spontaneously regress. Apart from that, because the child presents very early with a cancer and then is given chemotherapy, radiotherapy itself can give rise to some secondary malignancy. Many a times, the child will have some syndrome because it was born with some kind of germline mutation in any of the genes, right? Say for Wilms tumor, it is WT1, WT2. These are the genes. So the child was born with a germline mutation, say in WT1. But it can be sporadic, it can be syndromic. But because the child was treated with radiotherapy so early in age, at a later age can present with some other tumor like a leukemia or some other tumor. So that is also big. So we have to be very judicious with the chemotherapy, and we cannot just very aggressively treat a pediatric cancer. We have to be very judicious. Radiotherapy, you cannot just apply radiotherapy to the whole body. You have to, concentrate the radiotherapy to the location of the tumor so that we can avoid the generation of some other tumor elsewhere in the body, because radiotherapy itself can give rise to tumors in other places of the body. These are specific for pediatric age group tumors. Now, mostly the pediatric age group tumors, they look the same, right? It is very difficult for a pathologist to actually say what it is, especially if it has metastasized, and I am getting only the metastatic tumor. So it is very difficult to say because all of them look the same, small round blue cell tumors. They are called small round blue cell tumors because they will be round and very hyperchromatic blue, very little cytoplasm. They have a specific orientation of the cells, and that is called small round blue cell tumors, and this is the differential diagnosis for small round blue cell tumors: neuroblastoma, nephroblastoma, Ewing spinette, lymphoma, medulloblastoma, retinoblastoma, rhabdomyosarcoma. They can all look the same. Then we have to look for the age, location of the tumor, and then we decide, and some specific immunohistochemical markers, electron microscopic, some special features, or some chromosomal anomaly which is associated with that tumor, and then we differentiate what kind of tumor it is. We will discuss all of these, but mostly important for you is neuroblastoma and nephroblastoma. The rest, I will also touch upon the rest, but I think they will be discussed when they are when the specific systems are being discussed. So neuroblastoma. Neuroblastoma, most common location I said already. The people who are not listening, tell me. Common location for neuroblastoma. CR. কি করছো বসে? কি করছো ওখানে বসে? শুনছো? Then tell me. I already said neuroblastoma. Commonest location. It presents with a mass. Where? Neuro money brain হয়ে গেল তো. Where does it arise from? Where does it arise from? Sympathetic chain, and it most common location is abdomen. Neuroblastoma, if the child will present with an abdominal mass, fever, weight loss. For neuroblastoma, these are some specific features, and the age will be 0 to 4 years of age. So we will think about neuroblastoma. So if the question tells you, this is a very common MCQ. তোমরা pathology MCQ খুলে দেখো না? None of you are going to MCQs. একেবারে পাশ করে ফেসে যাবে. So the question lead will tell you that the child presents with an abdominal mass, fever, weight loss, etc., etc. Choose the option. You will be choosing neuroblastoma. Can also be Wilms. Wilms also presents as an abdominal mass. So the neuroblastoma, I told you already, arises from the sympathetic chain. It is a small round blue cell tumor. This is an example. You can see the cells are mostly round, very little cytoplasm, hyperchromatic cells with some mitotic figures. Now I'm not expecting you to diagnose mitotic figures, so forget it. But some mitotic figures are present. This. Anyway, and there are some, this is a kind of fibrillary pinkish background, and the cells surround this. This is called a rosette. It looks like a flower. This material and the cells. This is called Homer-Wright rosette. Homer-Wright rosette is a pseudo-rosette, and this central portion, this is called the neuropil. The fibrillary material is actually neural material, axonal material, right? So this is the central fibrillary material called neuropil, and the cells surround this, looking like a flower or a rosette. So it is called a Homer-Wright rosette. Homer-Wright rosette is not specific for neuroblastoma. It is found in other blastomas also, like medulloblastoma, can also be found in retinoblastoma. Retinoblastoma has another kind of rosette, which I will be discussing when I come to retinoblastoma. So this Homer-Wright rosette, it is also an MCQ, important MCQ that you have to know. So next, neuroblastoma, it is caused due to ALK1 gene amplification. ALK1 gene you have heard of, ALK1, right? Anaplastic lymphoma kinase. ALK1 gene amplification gives rise to neuroblastoma, and neuroblastoma specific markers are NSE, neuron specific enolase, NSE, and FOX2B. Have you had a class on IHC? IHC, immunohistochemistry. So these are IHC markers for, so whenever say we are getting a patient, a child presents with an abdominal mass, the mass is sent to us, we are getting a picture like this. Now we will go for some markers, because it can be WIMS, can be neuroblastoma, can be something else, can be lymphoma also. Lymphoma to lymphocytes, these look like lymphocytes to the uninitiated eye. These look like lymphocytes. When I was at your stage, everything looked like lymphocyte only to me. So these are lymphocytes. So how will we differentiate? Then we will go for some IHC markers. So for, if it is neuroblastoma, it will come back positive for NSE and FOX2B. Right? Now neuroblastoma, for all pediatric age group tumors, the prognosis varies, but if it is diagnosed at an earlier stage, the prognosis is good. 5-year survival is about 50 to 70%. If it is diagnosed at an earlier stage for neuroblastoma, there is international neuroblastoma staging system. According to that, we stage the neuroblastoma. You don't have to get into the details of it, but if it presents at an earlier stage, then the prognosis is good. Apart from that, there are some things like age less than 18 years, the prognosis is good. Age more than 18 years, prognosis is bad. Apart from that, diploidy, if there is hyperdiploidy, prognosis is good. But if there are chromosome breaks, in neuroblastoma we get a specific feature called chromothripsis. There are chromosome breaks, right? So if that is present, then the prognosis becomes bad. Apart from that, MYCN amplification. If it is present, prognosis is bad. Not present, prognosis is good. Neuroblastoma, I told it already, presents with an abdominal mass, can be congenital and can present, a child can be born. This is a very bad name for the child, blueberry muffin baby. Yes, but it is actually very sad for the child, right? But there is a dictum, যত ভালো ডাক্তারের জন্য তত বাজে পেশেন্টের জন্য. We get interested in cases, the worse the case, we are more interested in the case, but it is actually very bad for the patient. So we should always stick to saying interesting case. instead of ভালো কেসটা। একটা ভালো কেস আছে, ওয়ার্ডে গিয়ে দেখে আসি চল। Don't say that. Say interesting case আছে. I have also done it, so I know. So anyway, the child will be born with multiple cutaneous metastases of neuroblastoma. These are cutaneous metastases. Neuroblastoma can metastasize to lung, bone, bone marrow, liver, and skin. So this is called a blueberry muffin baby. Next question. A 28-year-old woman, gravida 1, parity 0, you will understand this in gynae. A 28-year-old woman has an uncomplicated pregnancy. This is her first pregnancy. G1 means first pregnancy. Gravida 1, parity 0 has an uncomplicated pregnancy until 28 weeks of gestation, when she develops uterine contractions and has premature rupture of membranes. This means the mother is suddenly delivering the baby at 28 weeks. It is early. And ultrasound reveals a lesion with representative gross appearance shown in the image. Which of the following is the most likely diagnosis of the lesion? People on my right side answer. What is the diagnosis? It is a teratoma. It is a sacrococcygeal teratoma. This question is from Robbins only, Robbins Review. Have you heard of the book Robbins Review? Next, nephroblastoma. This is a gross picture of a Wilms tumor. Now symptoms, again it presents as an abdominal mass. If it is a child less than 2 years presenting with Wilms, then the child will present with an abdominal mass. But if it is an older child, may not present with a mass, but will present with features of abdominal pain, hematuria, fever, weight loss and loss of appetite. These are the usual presenting symptoms of Wilms. Now Wilms is can be sporadic, can be syndromic. Sporadic is more common than syndromic, but the syndromes associated with Wilms are important. There are 3 syndromes associated with Wilms. I will tell you. R syndrome. It is called WAG-R syndrome because it is associated with Wilms. The syndrome, the symptom complexes are urinary abnormality. This is actually mental retardation, but we don't say mental retardation. We are politically correct these days, so we say mental insufficiency, but mental retardation, that is the classical name. It is associated with a WT1 is chromosome 11 P13 WT1. WT2 is also chromosome 11. You can only remember chromosome 11. You don't need to remember P13, P15.5, all that. So WAG-R. Apart from that, Denys-Drash presents with gonadoblastoma, male pseudo-hermaphroditism. Denys-Drash, and apart from that, child will present with end-stage renal disease because the child will have diffuse mesangial sclerosis of the kidney, which gives rise to glomerulonephritis. You will learn glomerulonephritis, nephrotic syndrome, all that once kidney starts. So one cause of childhood glomerulonephritis is Denys-Drash syndrome. Also WT1, same location. Apart from that, there is Beckwith, I think this is the spelling, Wiedemann syndrome. WT2. Beckwith-Wiedemann syndrome presents with hemihypertrophy, omphalocele, organomegaly, cytomegaly of the adrenals, and Wilms tumor. These all you have to know. Seems like a lot, I think, but still, you have to know all this because MCQ. So these are the syndromes associated with Wilms. Apart from that, it can be sporadic. Sporadic Wilms may or may not have mutation in WT1, can be associated with other genes like Drosha Dicer 1. These are associated usually with sporadic Wilms. Now, Wilms tumor is one of the tumors conquered by USA. Actually, because the mortality for Wilms was very high. About a few decades ago, mortality was about 70%. The 5-year survival rate was about 30%. Now it is 90 to 100% because Wilms tumor is very chemosensitive. It is a malignant tumor, but still it is very chemosensitive, and Wilms tumor can be bilateral, that is both kidneys can be affected by Wilms, or one kidney, and it can also happen that the child has Wilms tumor in one kidney at one time. After a few months, presents with Wilms tumor in the contralateral kidney. Even that can, metachronous and synchronous Wilms. That can also happen. Very sad for the child, very interesting for the doctor. So, Wilms tumor, and for Wilms tumor, looking for anaplasia is very important because it is associated with poor prognosis. Anaplasia is usually associated with, now tell me, guardian of the genome. Yes. So TP53 mutation is associated with anaplasia. In most cancers, TP53 mutation is associated with anaplasia, worse prognosis, and less chemosensitive. It can nullify the effects of chemotherapy more if the cell has TP53 mutation. That's it for Wilms. Yeah, what? Wilms tumor, okay, let me then get into the histology of Wilms. Wilms tumor is a triphasic tumor. First, so it has some nephrogenic rests. That is, from the nephrogenic rests in the embryonal, when the child is the embryo actually, during the embryonal time, from the nephrogenic rests, the kidney comes out of the nephrogenic rest. The kidney morphology develops from the nephrogenic rest. Now, from the nephrogenic rest, the Wilms tumor is can occur from the nephrogenic rest. In fact, say this is the Wilms tumor, right? This is the tumor. Now we have to sample from here. Here, this seems like apparently normal kidney, but this area can have nephrogenic rests, and this nephrogenic rest, if it is left in the kidney, that can give rise to Wilms tumor again. Like there can be a recurrence of Wilms tumor if the nephrogenic rests are present. So nephrogenic rests give rise to Wilms tumor. The Wilms tumor is a triphasic tumor. It has three components. It has an epithelial component, it has a blastemal component, and it has a spindle-shaped stromal component. The epithelial component actually forms some abortive tubules. You remember the glomerulus has tubules? So it will form some abortive tubules like this. Apart from that, there will be the blastemal component, which is the small round blue cell tumor. So it will be just looks like lymphocytes. This is the blastemal component of Wilms. Apart from that, it will have some spindle-shaped stroma. Now, renal cell carcinoma is a carcinoma which arises from epithelial component. So, Wilms tumor arises from the nephrogenic rest. Carcinoma arises from the epithelial component. So that is the basic difference. Apart from that, of course, age, etc., etc. Carcinoma can be clear cell carcinoma, chromophobe carcinoma, papillary carcinoma, etc., etc., etc. VHL is associated with and clear cell carcinoma, clear cell renal cell carcinoma. Next, these I will just touch upon. Rhabdomyosarcoma, it is a tumor of skeletal muscle. Malignant tumor of skeletal muscles is called rhabdomyosarcoma. Now, it can also be small round blue cell tumor, or it can have some other morphology. There are 4 types of rhabdomyosarcoma. Out of them, embryonal and alveolar are common in the pediatric age group. Rhabdomyosarcoma, the common locations are the head and neck paranasal sinuses. Apart from that, the gonadal region, uterus, ovaries, this area is common for rhabdomyosarcoma. Apart from that, these soft tissues are also common for rhabdomyosarcoma. These are the common locations. Apart from that, there is something called botryoid rhabdomyosarcoma. It has good prognosis, but it presents in very young patients. Say 1-year patient or 2-year-old patient can present with RMS. Botryoid, the specificity is it occurs in hollow organs like say hepatic canaliculi or blood vessels or vagina, commonly vagina. The child will present with a mass coming out of the vulva. The child is, say, a 1-year-old child presents with a mass coming out of the vulva. Then we see it can be botryoid rhabdomyosarcoma. Now, rhabdomyosarcoma can look like a skeletal muscle, can look like a small round blue cell tumor, and more or less these days more or less good prognosis if it is treated early. Resection, chemotherapy, radiotherapy, this is the usual treatment. And for alveolar rhabdomyosarcoma, associated with alveolar RMS, FOXO1. Next, Ewing's. Now, why have I put a picture of onions here? Because the radiographically there is a specific presentation. It is called onion skin appearance. Ewing's is a tumor of unknown origin. We don't know where it, like I told you, Wilms tumor arises from nephrogenic rest. Rhabdomyosarcoma arises from skeletal muscles. Now there are some tumors which are unknown. One of them is Pinette or Ewing's. We don't know where it arises from, can arise anywhere, most commonly bones, diaphysis of long bones, especially femur, humerus, these areas. There is a characteristic periosteal reaction which is called onion skin appearance. This is also an MCQ, and we pathologists, or in fact any doctor, has to always look for the MRI, for the X-ray. Pathology mane ami slide niye boshe gelam, never. First we always go for the X-ray. We have to know the X-ray. So this is the typical, there will be the onion skin periosteal reaction, and you can see these are just round cells, God knows what it looks like, right? Can have Homer-right rosettes. Maybe Homer-right rosettes can be present here. So there is a proposition that Ewing sarcoma also has a neural origin, because Homer-right rosette has a neural origin. So Homer-right rosettes are also present in Ewing sarcoma. Ewing sarcoma has a translocation. Can you tell the translocation for CML? Philadelphia. Similarly, Ewing's has a translocation. Chromosome 22, chromosome 11. Chromosome 22 has a EWSR1 with FLI1. This is the non-hematogenous translocation associated with cancer. So Philadelphia is a hematogenous translocation, right? So EWSR1 and FLI1 gives rise to Ewing's. And specific marker for Ewing's is CD99, IHC marker. We will always say we get a small round blue cell tumor, so we will have a specific IHC panel, and one of that will be CD99. Apart from that, NSE, chromogranin, forget it. Osteosarcoma. Osteosarcoma also has a there is a specific name for this. Do you know? The specific periosteal reaction. What is a periosteal reaction? The bone has a periosteum. You know that from anatomy, the bone has a periosteum. So if there is even an infection or trauma or growth gives rise to a reaction where the periosteum becomes active, it can be raised like this. So this is called a periosteal reaction. Now, osteosarcoma is a very aggressive tumor which raises the periosteum this much. And this is called Codman's triangle. The periosteum forms with the main bone. This triangle is called Codman's triangle, associated usually with osteosarcoma. Osteosarcoma is aggressive. You can see this is the gross morphology. This is also important. This is a tumor which has broken through the bone and gone into the soft tissue. The usual, this is the bone, you can see, this is the bony trabecula, and this is the mass. This entire thing is the mass. It arises in the metaphysis of long bones, usually around the knee joint, that is femur, tibia, lower end of femur, proximal end of tibia. And it will be an adolescent age group child, usually male, and a common presentation. I have seen, like the first case I saw when I asked, it was a 17 or I think 15 or 17-year-old boy, and said, "Amar paye legechilo, tarpor theke erokom hoye geche." They will always say that because it comes to attention usually when they have some kind of trauma, because it is also associated with pathological fractures. What is a pathological fracture? I am asking this because I don't know if you understand what is meant by a pathological fracture. Do you know what is a pathological fracture? No, that any fracture can be caused by trauma. Yes. Where this much of trauma would not be sufficient to cause a fracture. But the bone is not healthy, and that is why minimal trauma gives rise to breakage or fracture of bone. That is called a pathological fracture. Another tumor associated with pathological fracture, very common, elderly. Learn to correlate. Tumor. Multiple myeloma. You had exam. Many of you came, when I asked multiple myeloma, many of you came and said pathological fracture. But you have been just mugging up and you have forgotten. So osteosarcoma can also present as pathological fracture. Even Ewing's can present as pathological fracture. So it is an aggressive tumor, and the tumor will have these kinds of osteogenic. This is new bone formation. These are bones actually. It gives rise to these new bone, and there will be mitotic figures, and it is very aggressive, very cellular. There will be necrosis. Now, name the gene associated with osteosarcoma. RB gene. Right. And osteosarcoma, whenever a patient presents with osteosarcoma, it is considered that it has already metastasized. Have you seen the movie Fault in Our Stars or read the book? You have? So the main character, he had, yes, he was suffering from osteosarcoma, which had metastasized to lungs, right? I think, and then he passed away in the book. Have you read? I read the book. I didn't see the movie. And then again, oi, Dil Bechara. Yes, yeah, that was the original movie had the original book had osteosarcoma only. So young male patient presents with it is considered that the patient will already present with a metastasis. And usual site for metastasis is lungs, can be brain, can be liver. In lungs, it will be multiple metastases. Snowstorm appearance of lungs associated with osteosarcoma. Many metastases, right? Apart from RB, the other gene mutations associated with osteosarcoma is TP53 and CDKN2A, CDKN2B, MDM2, and CDK4. These are associated with the regulation of which gene? MDM2 regulates which gene? MDM2 regulates which gene? RB. So RB gene, again, if MDM2 mutation takes place, RB gene dysregulation takes place and again can give rise to osteosarcoma. Next, medulloblastoma. What is this? These arrows. Yes, Homer-right rosette. The neuropil in the center and surrounded by these small round blue cells. So medulloblastoma occurs in the cerebellum. By definition, arises in the cerebellum always. Younger age patients, here you can see, this is obviously an autopsy, cannot be from the main. Nobody takes out the brain. So here the cerebellum, there is a mass replacing the vermis here. So this can be a medulloblastoma. This is the microscopic picture. There can be Homer-right rosettes. And for medulloblastoma, there is a specific pathway in which there is dysregulation, that is the SHH. SHH, sonic hedgehog pathway. This dysregulation takes place and gives rise to medulloblastoma. Other genes associated, WNT beta catenin, right? Medulloblastoma again has a very good prognosis with a 90% 5-year survival rate. Lastly, retinoblastoma. Retinoblastoma again can be a small round blue cell tumor, and retinoblastoma arises from neural component only. In the retina, there is a neural component. Retinoblastoma arises from the neural component, can be sporadic, can be syndromic, which is the two-hit hypothesis, Knudsen two-hit hypothesis, which was studied in retinoblastoma. A child can be born with one mutation in RB, and then during the lifetime there is another mutation which is early in the childhood only, and then it gives rise to retinoblastoma in syndromic maybe, and or can be the child was not born with any mutation, but there is mutation in RB, two hits of mutation in the two RB genes, one paternal, one maternal. In the two RB genes, there is mutation during the lifetime and can give rise to retinoblastoma. Now, retinoblastoma has wide areas of necrosis, and these are the small round blue cells. What is this? This white arrow is pointing. What is this? And again a rosette, it is a rosette. You can see this pink area surrounded by blue cells. The pink area will be surrounded by these blue cells. Now retinoblastoma, and this is another area. What is this? Do you know? This is an area of calcification. If there is a wide area of necrosis, that can give rise to calcification. What kind of calcification is this? Dystrophic. The dystrophic calcification. Now retinoblastoma can have Homer-Wright rosette, this one, or can have this kind of rosette. This is called a Flexner-Winter-Steiner rosette associated with retinoblastoma. It is again an MCQ. Flexner-Winter-Steiner rosette. So, Flexner-Winter-Steiner rosette seen in? চুপ করে বসে থাকবে, কিচ্ছু শুনবে না, পরীক্ষায় গিয়ে উত্তর দেবে না, লিখবে না। Flexner-Winter-Steiner rosette seen in? You don't know? Please stand up when I'm asking you a question. Green shirt, please stand up. Yes, you. Retinoblastoma. 4 বার বলেছি। বস। So, common tumors in infancy and childhood. Benign, malignant. Benign tumors. Malignant tumors. CNS, medulloblastoma, eye, abdomen, neuroblastoma, Wilms, soft tissue, Ewing's. Okay, that's it. Thank you.
The renin is secreted from kidney. So juxtaglomerular cells of the kidney, juxtaglomerular cells are present in the lining of the afferent arterioles. So renin is secreted basically as prorenin. Okay, so I am giving first the nutshell of this. So prorenin is the pro form of the renin. That prorenin is clipped to renin. Okay, and that renin is stored within the kidney, and it was secreted when there is some stimulus. There are important stimulus that will secrete the renin. Most commonly the stimulus is when there is renal perfusion changes, that is the blood flow to the renal artery changes. Next is when the macula densa senses that the sodium and chloride is less, so that they will try to conserve the sodium and chloride. So these two are the main. Another third one is the beta agonism. So beta receptor agonist, if there is present, that will also leads to renin activation. Now renin activation of the renin ultimately causes the angiotensinogen. This angiotensinogen is secreted from the liver. It is converted to angiotensin 1 and then it is converted to angiotensin 2 by means of the renin. And this angiotensin 2 peptide is the main part of this renin-angiotensin system. This angiotensin 2 mainly causes, in short, increases the blood pressure. So angiotensin 2 causes vasoconstriction, they ultimately causes anti-apoptotic activity. Ultimately all this leads to increased blood pressure. Okay, aldosterone, you also know the aldosterone, you have probably read in the diuretics chapter. So aldosterone is another part of this renin-angiotensin-aldosterone system that also increases the blood pressure. So ultimately all these renin, angiotensin and aldosterone, the main part is when there is hypotension, when there is less sodium and chloride in our body, to increase the sodium chloride in our body and to increase the blood pressure. Now when there is overactivation of the renin-angiotensin system, that is the renin-angiotensin system is overly activated, so that there will be hypertension. So in your family, I think some of you have in your family have hypertension, and they are taking some medications, antihypertensive drugs. You will read antihypertensives in detail in the Friday and Saturday class, but this is the basics of all the drugs. Mainly those are used in the cardiovascular fronts. So if we can block this renin-angiotensin-aldosterone system, ultimately that will help in decreasing the blood pressure. Ultimately that also helps decrease the cardiac remodeling. That is, that can help in ischemic heart disease, that can help in cardiac failure and different types of the other cardiovascular morbidity and mortality. So this is the basics of the renin-angiotensin system. So angiotensin 2, what I am telling, that this is the main parts of this system, which is basically the octapeptide. It is generated in the plasma from a precursor plasma alpha-2 globulin. It is secreted from the liver, which is involved in electrolyte, blood volume and pressure homeostasis. So this system is basically maintains the electrolyte balance. This system maintains the blood pressure. This system maintains the pressure homeostasis. The pressure action of the kidney extracts was known since 19th century. So since 19th century, there is something chemical is present. It was known, and since it is obtained from the renal, it is known as the renin. Okay. Now this product of the renin action was an inactive angiotensin 1, which is converted to angiotensin 2 by means of angiotensin-converting enzyme. What I am already talking. So angiotensin 2 is formed from the angiotensin 1 by cleaving by angiotensin-converted enzyme. Normally the amount of renin in plasma acts as limiting factor for angiotensin 2 generation. So there is balance. So balance that maintains the normal blood pressure in our body. So in our body, when there is no hypertension and hypertension, it is maintained by angiotensin 2 as well as renin production. They will balance each other. But when there is overactivation or overproduction, there will be increased blood pressure. The plasma T-half of renin is 15 minutes. This is the half-life. Biological potency of angiotensin 1 is only 100 that of angiotensin 2. That's why angiotensin 2 is the main pressure substance. Pressure substance means that increases the blood pressure. Angiotensin 2 is the main pressure substance. It is rapidly converted to angiotensin 2 by angiotensin-converting enzyme. This enzyme is basically a dipeptidyl carboxypeptidase. It is an ectoenzyme located primarily on the luminal surface of vascular endothelial cells, especially in the lungs. So remember, in the lungs, there is vascular endothelium. From this endothelium, angiotensin-converting enzyme is secreted. This angiotensin-converting enzyme, in presence of the renin, converts the angiotensin convert to angiotensin 1, it is converted to angiotensin 2. And angiotensin 2, in all prospects, it increases the blood pressure. In short, circulating angiotensin 2 also has a very short T-half. Now this RAAS, this system is directly involved in renovascular hypertension. That is hypertension that is caused mainly due to the changes in the perfusion and activity of the kidney. This is known as the renovascular hypertension. Plasma renin activity is raised in most patients. So renin level, plasma renin activity, this can be measured. Okay, so this is a measurable value. Plasma renin activity is increased in renovascular hypertension. In essential hypertension also it appears to have a permissive role. That is, in collaboration with other factors, it also increases the blood pressure in normal systemic hypertension. So when you will read hypertension, you will see that most of the cases of the hypertension, 80 to 90% are caused, that is the idiopathic, that is exact cause is not known. This is known as the essential hypertension or primary hypertension. Apart from this, there are different types of the secondary hypertension, that is hypertension caused by different other agents, caused by different other disease, caused by other problems like renovascular hypertension. In all of these cases, the renin-angiotensin system plays an important role. Now the first degradation product produced by the action of this aminopeptidase is angiotensin 3. That is, it is also converted to angiotensin 3 after the angiotensin 2, but it is less potent. It is again attacked by another aminopeptidase and it is again converted to angiotensin 4. So this is the metabolism of the angiotensinogen in fact. So it has very different central and some peripheral actions, mainly to specific angiotensin 4 receptors. This is not needed, but the form is that the system does not end at the angiotensin 2, angiotensin 3 and 4 are also formed, and they also acts by different types of the other receptors like angiotensin 4 receptors. Both angiotensin 3 and 4 are broken into inactive fragments by non-specific peptides termed as angiotensinases. So basically, ultimately it cleaved and ultimately it passes through the urine and stool. So by this the metabolism of the angiotensinogen happens. So this is, you can see, so this is the angiotensinogen. So angiotensinogen mainly formed from the plasma alpha 2 globulin. So when there is low macula densa sodium and chloride, so what I am telling, so when there are sodium and chloride level is low in the macula densa, when there is low glomerular afferent pressure, and when there is enhanced sympathetic activity like beta agonism, and it happens when there is sodium chloride loss. So when, for example, when there is hypotension, for example, there is you can see when there is accident, there is hypotension, there is severe bleeding, or if there is severe dehydration, there is severe loose stool or vomiting. In all these cases, sodium chloride level is less, and the kidney contains the juxtaglomerular cells, macula densa. They will sense that the sodium chloride level is less. They then activates this. Fall in blood volume. Blood volume falls when there is some accidents, when there is fluid loss from the body, when there is dehydration. Fall in blood pressure in all these cases, or renal ischemia, that is the renal blood flow when it is compromised. If the renal blood flow is compromised, the kidney cannot act as it should act. So all this leads to these problems, and ultimately this leads to activation of the renin, more actions of the renin. Now renin in the juxtaglomerular cells converts this angiotensinogen to angiotensin 1. Again, when there is rise of blood pressure or increased blood volume, ultimately that balances, that is, that inhibits the renin mediated activation of the angiotensinogen to angiotensin 1. Now this angiotensin 1 in the presence of the renin and by means of the angiotensin converting enzyme, which is obtained from the vascular endothelium, converts to angiotensin 2. And this angiotensin 2 is an octapeptide, contains 1 to 8 peptide molecules, and this is the main pressure response that causes vasoconstriction. And again, when there is vasoconstriction, ultimately that leads to increase of the blood pressure. And again, this is like a feedback mechanism. So when there is increased blood pressure, that will ultimately lead to less secretion of the renin, less activation of the renin, and again it will be balanced. Again, it will be converted to angiotensin 3 and angiotensin 4. So sodium water retention, aldosterone secretion from the adrenal cortex, all this can lead to increased blood volume, and again by means of the feedback inhibition, it is balanced. So basically this is a physiological mechanism. But when this physiological mechanism becomes pathological, when there is overactivation, then there occurs hypertension and other cardiovascular problems. So there are basically two types of the systems are present. One is extrinsic local and another is intrinsic local. Extrinsic local, here apart from angiotensin 2 generated in circulation, blood vessels capture circulating angiotensinogen. So blood vessels are present, and renin to produce angiotensin 2 at the surface of their wall. So blood vessel wall itself can capture the angiotensin and renin to form the angiotensin 2. This angiotensin 2 diffuses to act locally on the angiotensin receptors, producing localized response. So not only the systemic response, localized response, that is localized vasoconstriction also happens, and ultimately it helps in controlling the peripheral vascular resistance. You know from the physiology that both the peripheral vascular resistance, that is the afterload, preload and afterload, both are instrumental in maintaining the blood pressure as well as increased blood pressure. So here also local renin-angiotensin system also plays a part in increasing the blood pressure. And intrinsic local RAAS is the many tissues like heart, blood vessel, brain, kidney, adrenals. They possess the capacity to synthesize the all components of this system within their cells. So they generate the angiotensin 2 and 3 intracellularly and are instrumental in regulating the organ function, cell growth like hypertrophy, cell death like apoptosis, remodeling and fibrosis. So what happens when there is increased blood pressure for long period of time? there occurs hypertrophy because the heart have to do actions more. So when we have to do actions more, our muscles will hypertrophied, like the heart will also hypertrophied. So hypertrophy of the heart, increased cell growth occurs. So when there is increased growth of the heart, that is known as the hypertrophy of the heart, like left ventricular hypertrophy, very common in hypertension. And when hypertrophy happens, the heart becomes exhausted. So heart have to do more pressure to do the same amount of the work, and ultimately that leads to increased peripheral vascular resistance, decreased preload, and there occurs more chances of the cardiovascular failure, heart failure it is known as. Now coming to the prorenin and renin receptor. So renin is synthesized already, I have told that it is synthesized in the form of the prorenin, okay. So in response to stimuli, both prorenin and renin are secreted, the former in much larger quantities. So larger amount of the prorenin is secreted. Concentration of the prorenin in circulation is approximately 5 to 10-fold higher than that of renin. And prorenin was considered inactive precursor, but now it is recognized that it has its own pressure response also in some of the cases, mostly local responses are present. So enzymatic activation of the prorenin is caused by the pro-convertase 1 and cathepsin B. So this pro-convertase 1 and cathepsin B cleaves the prorenin to renin. Non-enzymatic and reversible activation occurs by binding of the prorenin to another cell surface protein. This is known as the prorenin receptor. So prorenin receptor is also present apart from the renin receptor, and this is richly expressed in heart, blood vessel, kidney, brain, eye and liver. Apart from this, non-enzymatic activation of the prorenin plays a major role in local renin-angiotensin system. What I am talking. So in the local area, already we have seen that in the local vasoconstriction, they also, this prorenin receptor also plays a role. Prorenin exerts effects. So you can see the prorenin by means of the enzymatic activation or non-enzymatic activation. Two types of the activation can happen. It is converted to renin, and renin again acts on the angiotensinogen. And this was done by the pro-convertase 1 and cathepsin B. Apart from this, non-enzymatic activation also happens mainly in the local areas, that is in the blood vessels of the different organs like heart, liver, lungs, etc., where it can lead to local pressure responses. And this prorenin receptor, ultimately this prorenin is cleaved to renin, and by means of the non-enzymatic augmentation, it converts the angiotensinogen to angiotensin 1, and then it converts to angiotensin 2. So this is the areas by which the prorenin and renin are instrumental in making the conversion of angiotensinogen to angiotensin 1. So renin-angiotensin system, basically you can see the one is angiotensin 2 dependent pathway, and there is another that is known as the angiotensin 2 independent pathway. So dependent pathway is where the activation of the prorenin and renin generates the angiotensin 1. So angiotensin 1 is generated, the same thing, which is converted to angiotensin 2 by means of the angiotensin convertase enzyme. Angiotensin 2 acts on angiotensin receptors, AT receptors, this is known as, on the tissue cells to produce effects on cell growth, inflammation, apoptosis, etc. So same thing, that is important, that's why the similar thing I am talking. And apart from this, there is another independent mechanism where the binding of the prorenin or renin to prorenin receptor on cell surface directly triggers the intracellular signaling via different types of the kinases like MAP kinase, JAK-STAT pathway, plasminogen activator inhibitor, different other transcription factors, pro-oncogenes, etc. to regulate the cell growth, collagen deposition, fibrosis and apoptosis. Both of these angiotensin, that is angiotensin 2 is basically through the angiotensin 2X, and it acts directly by activation of the different transcription factors, let's remember. And both of these two are instrumental in making the different cardiovascular diseases. You can see this is the prorenin renin, this is the prorenin receptor. This is the angiotensin 2 dependent pathway where it converts the angiotensin 1 to angiotensin 2 from angiotensinogen. This is the normal pathway where non-enzymatic activation or augmentation happens. And this is angiotensin 2 independent pathway which acts directly to different types of the transcription factors by means of the intracellular signaling like MAP kinase, JAK-STAT pathway, etc. like MAP kinase, plasminogen activator, inhibitor 1, JAK-STAT pathway, different types of the proto-oncogenes, etc. This angiotensin 2 also activates all these different types of the kinases, but this is direct by means of the angiotensin 2, and all this leads to cell growth, fibrosis, apoptosis, remodeling of the myocardium or vascular muscle, nephropathy, retinopathy. That is, all these problems can happen when it is not balanced or not restricted. Okay, so this is the pathway by means of the renin, prorenin, by means of the angiotensin 2 dependent pathway or angiotensin 2 independent pathway acts on different cells, particularly on the heart. This is acts on the different heart muscles, like heart muscles, hypertrophy, apoptosis, retinopathy, nephropathy, etc. So, what are the actions of this system, particularly angiotensin 2? So, the most prominent action of the angiotensin 2 is vasoconstriction. So, constriction of the vessels. Now, if the constriction of the vessels happens in different organs, and accordingly the different effects happens. So, as well as it also enhances the adrenaline and noradrenaline release from adrenal medulla or adrenergic nerve endings, and by increasing the central sympathetic outflow. You can see all this can increase the blood pressure. So, they can increase the blood pressure if there is increased noradrenaline release or increased adrenaline release, increased central sympathetic outflow, etc. This vasoconstriction promotes movement of the fluid from vascular to extravascular compartments. So, vessels থেকে বাইরে অনেকটা জমা হবে, যার ফলে there is more chances of the edema formation, more chances of the in the heart, more chances of the congestive cardiac failure, congestion, that is the fluid is present in the extravascular tissue. If it is injected IV, angiotensin 2, it is much more potent than noradrenaline as a pressure agent. Until now, we know that the noradrenaline is very much potent in increasing the blood pressure, but it has been seen this angiotensin 2 is much more potent than noradrenaline itself. It increases the force of myocardial contraction by promoting calcium influx. That is, more calcium is included within the sarcolemmal membrane, that ultimately leads to more force of myocardial contractions. Cardiac output is often reduced and cardiac work is increased. Cardiac work, that is work of the heart, is increased, and ultimately when it is continuing, the cardiac output, that is the amount that is delivered to different tissues, will be decreased, because the preload is gradually decreased and afterload is gradually increased, and ultimately due to rise in the peripheral resistance, that is the afterload. It acts on the chronic basis, that is, if it is this overactivation of the renin-angiotensin system, ultimately this is not an acute process, it ultimately happens for months or years. Ultimately leads to hypertrophy, hyperplasia, and increased intracellular matrix production in the myocardium and vascular smooth muscle. What I am telling. So, ultimately the size of the heart increases. So, there will be hypertrophy, hyperplasia of the cardiac muscle cells. Indirectly, volume overload. Since there is extravasation in the extravascular compartment, increased total peripheral resistance caused by angiotensin 2 contributes to the hypertrophy, and this is also known as the remodeling of the heart and blood vessel cells. So, abnormal redistribution of the muscle mass happens, remodeling, and ultimately this leads to left ventricular hypertrophy or right ventricular hypertrophy or left atrial hypertrophy or right atrial hypertrophy. If you have any member of your family have hypertension for long period and you will do a echocardiography, perhaps some of you have done, you will see that most of the cases there is left ventricular hypertrophy is present, because there is unopposed renin-angiotensin system. This angiotensin 2 and 3 are trophic to the zona glomerulosa of the adrenal cortex, zona glomerulosa. They enhance synthesis and release of the aldosterone. Already we have read in the diuretics chapter aldosterone. This aldosterone acts on the distal tubule of the kidney. The main actions of the aldosterone is to promote sodium reabsorption and potassium H+ excretion. They are again same thing. So, they reabsorb the sodium, reabsorb the chloride. So, ultimately reabsorb the water, increase the blood pressure. But this aldosterone is synthesized from the adrenal cortex. Already you have seen zona glomerulosa part of the adrenal cortex, and this angiotensin 2 ultimately causes increased release of the aldosterone from the zona glomerulosa cells. It promotes sodium H+ exchange in proximal tubule, So exchange occurs and increased sodium chloride SiO2 plus reabsorption. So more reabsorption of the sodium chloride occurs. Reduces renal blood flow and glomerular filtration rate. Increases central sympathetic outflow. An important role in maintaining the electrolyte composition and volume of extracellular fluid. The same thing. And low sodium and chloride concentration in the tubular fluid sensed by macula densa cells triggered this pathway. Already we have discussed. So mainly it is triggered by this. So two receptors are the main, angiotensin 1 and angiotensin 2, 81 and 82, both are G protein coupled receptor. Just remember this. So increased renin is translated into increased plasma angiotensin 2, which produces acute rise in blood pressure by vasoconstriction. Same thing. Now the long lasting effects by directly and indirectly increasing the sodium and water reabsorption in the kidney. Already we have read. Rise in blood pressure in turn inhibits the renin release, the long loop negative feedback mechanism in the physiological circumstances. Ultimately, it checks. Angiotensin 2 can be formed within the kidney and exerts important local regulatory effects. There are another short loop negative feedback mechanisms within the kidney. Activation of the angiotensin receptors on juxtaglomerular cells inhibits the renin release directly. That is, whenever there is increased renin or increased angiotensin 2, ultimately that will increase the blood pressure, and if there is physiological, ultimately that will inhibits the renin release, inhibits the angiotensin converting enzyme release, inhibits the angiotensin 2 formation. It is physiological. Long-term stabilization of the blood pressure happens despite varying salt and water intake in physiological, in our body. So ultimately this action, this system is continuously in action. So when we are in the hypovolemic state, when there is diarrhea or when we are deprived of the water for long period of time, it acts, and ultimately long period of the time the blood pressure stabilization happens. Now coming to the inhibition of the renin-angiotensin system, how we can inhibit this system by different types of the drugs. Firstly, the sympathetic blockers like beta blockers. Already we have seen this. Ultimately, beta agonism helps in increased renin release. Central sympathetic pathway is increased when there is renin activation, this system activation. So when we are blocking the beta receptors, beta blockers, adrenergic neuron blockers, central sympatholytics, that blocks the central sympathetic outflow, all these decrease the renin release. So ultimately angiotensin 2 production will be decreased. So sympathetic blockers. Already we have discussed about the sympathetic blockers in ANS. Now coming to the direct renin inhibitors. So block the renin action. They interfere with generation of the angiotensin 1 from angiotensinogen, and which is the rate limiting step. The most common drug of this group is the aliskiren. Okay, aliskiren is the drug under the direct renin inhibitors. Now coming the two most important drugs, angiotensin converting enzyme inhibitors and angiotensin receptor blockers, ACE inhibitors, which prevent the generation of the active principle of the angiotensin 2, and this angiotensin receptor blocker, this blocks or antagonize the action of the angiotensin 2 on target cells by blocking the receptor. Apart from this, there is aldosterone antagonist, already you have seen, that block the mineralocortical receptors. So mainly in this, we will mainly deal with these three, the ACE inhibitors, ARBs and the direct renin inhibitors. We will know about the beta blocker or everything in the ANS and aldosterone antagonist etc. in the diuretics. So now coming to the angiotensin converting enzyme inhibitors. This is very important group of the drugs, off and on used in the management of the different cardiovascular diseases, most commonly hypertension, you will see. So captopril is the prototype drug that was first discovered in 1977. Apart from this, these are the other examples of the angiotensin converting enzyme inhibitors or ACE inhibitors, ACEI. Example: captopril, enalapril, lisinopril, benazepril, ramipril, fosinopril, quinapril, imidapril, etc. Of these, remember the captopril, enalapril and ramipril. These three are most commonly used. Okay. Captopril, enalapril and ramipril. This angiotensin converting enzyme, already we have seen, it is a relatively non-specific enzyme. This splits off the dipeptidyl segment from the several peptides apart from angiotensinogen. So substance free, bradykinin, other agents also cleaved by means of this angiotensin converting enzyme. So as a result, this can increase the plasma kinin levels. So kinin is a cytokine that is present within the plasma. That's volume is increased when it is blocked and potentiates the hypotensive actions of the exogenously administered bradykinin. So bradykinin is again a cytokinin. It has been seen that if we are giving this, ultimately the actions of the bradykinin is increased. So elevated kinins. So when we are giving the angiotensin converting enzymes, the kinin level is elevated and ultimately the prostaglandin level is also elevated because this prostaglandin synthesis is enhanced by the kinins. And this elevated prostaglandins due to the elevated kinins is responsible for the cough and angioedema, which is induced by the AC inhibitors in susceptible individuals. This is very important. So the question is asked, why AC inhibitors causes cough and angioedema? Because the angiotensin converting enzyme is not specific for angiotensinogen alone. It also cleaves other peptides like different types of the kinins, most commonly the bradykinins. Now when it is cleaved, ultimately the prostaglandin synthesis also enhanced because the kinins becomes activated. So ultimately that leads to cough and angioedema by means of the AC inhibitor. They also interferes with the degradation of the substance P. Substance P is instrumental in pain modulation, beta. Rise in the level of the stem cell regulator peptide caused by AC inhibitors responsible for congestive heart failure. That is, if we are blocking the angiotensin converting enzyme, that also controls the problems in the congestive heart failure. You will read the congestive heart failure later. Now the response is dependent on sodium status and the level of the RAAS activity. So whether the RAAS is overactivated, what is the amount of the sodium, etc. In normotensive, that is there is no hyper or hypotension. Sodium replete individuals, that is sodium level is normal. The fall in blood pressure attending initial few doses of the AC inhibitor is modest. So when the sodium is depleted more, or when there is hypertension, in those cases, if we are using this AC inhibitor, the action will be more. That is, in normal individuals, if you are giving a AC inhibitor, the actions will not very much. That is, it will not decrease the blood pressure more, but in hypertensive individuals, it will decrease the blood pressure more. So AC inhibitor therapy has to be started in the lower doses. Greater fall in blood pressure occurs in renovascular, accelerated and malignant hypertension. So these are the different other hypertension that cannot be tackled by normal medications. There will be increased systolic and diastolic blood pressure, and ultimately that greater fall of the blood pressure occurs if we are giving the angiotensin converting enzyme inhibitors. Essential hypertension, it has been seen the RAAS is overactive in 20%, normal in 60% and hypoactive in the rest. So 60 plus 20, 80%. So in essential hypertension, if we are giving these drugs, ultimately that helps in the 80% of the population in decreasing the blood pressure. The arterioles dilate. So basically they are contradicting the actions of the angiotensin 2. So angiotensin 2 all are vasoconstriction. They are opposing the vasoconstriction to dilatation. So the arterioles dilate. Compliance of the larger arteries is increased. Systolic and diastolic blood pressure falls. It has no effect on cardiac output. Cardiovascular reflexes are not interfere, and postural hypotension is not a problem. That is, blood pressure is not decreased rapidly so that there will be vertigo. Reflex sympathetic stimulation does not occur despite vasodilation. So these are the adverse effects of the AC inhibitor. Again, this is very important. So adverse effects of the AC inhibitor is asked in the viva as well as in the theory. So hypotension. Hypotension is modest, not very much. It occurs especially if the patient is already on some diuretics and in congestive heart failure patients. Persistent hypertension may be troublesome in myocardial infarction, because myocardial infarction also this AC inhibitor is given, but in some of the patients there will be persistent decrease of the blood pressure. In those cases it should be stopped. Hyperkalemia, more likely in patients with impaired renal function and in those taking potassium sparing diuretics. You have read in the diuretics chapters about the potassium sparing diuretics like spironolactone, NSAIDs or beta blockers. So if the patient is already continuing on these drugs, we should be cautious about the potassium level, because the potassium level can increase. Hyperkalemia can occur and hyperkalemia can lead to cardiac arrhythmia. That's the problem. We have seen how cough happens. Persistent brassy cough occurs in 4 to 16% of the patients within 1 to 8 weeks of the starting. Often requires discontinuation of the drug. We have to stop the angiotensin-converting enzyme drugs. Subsides 4 to 6 days thereafter. It is not dose related, caused by inhibition of the bradykinin or substance B breakdown in the lungs. Most of the cases, we have to replace this with the angiotensin receptor blocker. So this is the question, that if a persistent brassy cough occurs with an ACE inhibitor, what will you do? So if it will become very much troublesome, we have to stop the drug. It will be subside 4 to 6 days thereafter. Again, we can start the drug. In some of the cases, the cough will not happen. But in those cases where the cough will be continuing, we have to replace the ACE inhibitor with the angiotensin receptor blockers. And there will be no cough with the angiotensin receptor blockers. RAAS urticaria can happen, angioedema can happen, swelling of the lips, mouth, nose, larynx can develop within hours to few days in very less, 0.06 to 0.5% of the patients. But this is problematic because that can cause airway obstruction that leads emergency management. This can be treated with adrenaline, antihistaminics and corticosteroids. So angioedema can happen in very less percentage of the ACE inhibitors patients, but it is of emergency. You have to tackle with adrenaline, antihistaminics and corticosteroids. Dysgeusia means reversible loss or alteration of the taste sensation. A metallic taste happens in the tongue. Fetopathic, remember it is a teratogenic drug, ACE inhibitor. Fetal growth retardation can happen. Hyperplasia of the organs and fetal death may occur if ACE inhibitors are given during latter half of the pregnancy. So in case of the pregnancy, you have to stop the ACE inhibitor. Okay. Headache, dizziness, nausea, bowel upset can happen in very less percentage of the cases. Granulocytopenia, proteinuria can happen. And another important thing, in case of the bilateral renal artery stenosis, if you are giving the ACE inhibitor, that can precipitate acute renal failure. So bilateral renal artery stenosis. So in both of the cases, renal artery that supplies the kidney, stenosis can happen. So in bilateral renal artery stenosis also presents with very high rise of the blood pressure. In those cases, if we are giving ACE inhibitor, acute renal failure can happen. So this is a contraindication of the ACE inhibitor. Very important. Bilateral renal artery stenosis is a contraindication of the ACE inhibitor. Enalapril is the most commonly used. You can see now, second ACE inhibitor. It is a prodrug, more potent, usually given once daily or twice daily. Onset of action is slower, longer duration of action. Most of the cases, all the properties are similar to already discussed. Rashes and loss of taste are less frequent. Ramipril is another drug that is used. Distinctive feature is extensive tissue distribution, greater inhibition of the local rash. Already we have seen that there are local rash as well as systemic. Local rash inhibition also happens by means of the Ramipril. Now, where it is used, ACE inhibitor, hypertension. Most important, hypertension. The hypertensive effect of the lower doses develops gradually over 2 to 3 weeks. So it takes time for 2 to 3 weeks. And they offer the following advantages. Key advantage আছে? Free of postural hypotension, electrolyte disturbance, feeling of weakness and CNS effects. It is safe in asthmatics. There will be no bronchoconstriction. It is safe in diabetics. There is no hyperglycemia and peripheral vascular disease. Long-term ACE inhibitor therapy has the potential to reduce incidence of the type 2 diabetes in high-risk subjects. It has been shown in the trial. Secondary hyperaldosteronism, that is the high aldosterone level increase secondarily, and potassium loss due to diuretics can be prevented if we are combining. Renal blood flow is well maintained. So these are the advantages. Left ventricular hypertrophy and increased wall to lumen ratio of the blood vessels is reversed. Already I have discussed in hypertensive patients, hypertrophy of the heart happens. This hypertrophy of the heart can be reversed by means of the ACE inhibitor. No hyperuricemia, that is uric acid is not increased. No deleterious effect on plasma lipid, that is plasma lipid profile is not altered. No rebound hypertension on withdrawal. হঠাৎ করে বন্ধ করলে খুব বেশি করে ব্লাড প্রেসার বেড়ে যাবে না। Minimum worsening of the quality of the life, like general well-being, work performance, sleep, sexual performance, etc. There is no changes. And these changes can happen with the beta blockers. Beta blocker is also an antihypertensive, but these problems happen. Reduce cardiovascular morbidity and increase life expectancy of the hypertensive patients. So if we are continuing for long term, the life expectancy, the survival benefit happens. It appears that by the specific effect on myocardial and vascular cell growth or remodeling, because they are decreasing, because they are blocking the angiotensin converting enzyme, they are decreasing the remodeling, decreasing the hypertrophy, and ultimately greater protective potential than other classes of the antihypertensive drugs. That's why they are very much protective, they have survival benefit. So these points are the advantages of the ACE inhibitor over other agents in case of the hypertension. Now it can be used in congestive cardiac failure all happens because they causes vasodilation both in the arterioles as well as in the venules. Reduction in the right arterial pressure, pulmonary arterial pressure, pulmonary capillary wall pressure, systemic vascular resistance, systolic wall stress. That is, these are the different points ultimately that leads to increased blood pressure. All these are decreased. Diuresis occurs initially when we are giving this, and accumulated salt and water are lost due to improved renal perfusion and abolition of the mineralocorticoid mediated sodium retention. Cardiac work, which is measured by the heart rate and pressure product, is reduced. So ultimately congestive heart failure, the heart rate reduced, the cardiac work is reduced, and ultimately the symptoms of the congestion are relieved when the ACE inhibitor is given. Myocardial infarction, that is a heart attack. Oral ACE inhibitors usually administered while myocardial infarction is evolving. That is, already myocardial infarction happens within 24 hours and it is continued for 6 weeks. It reduces early as well as long-term mortality. That is, death from the myocardial infarction can be decreased irrespective of the presence or absence of the systolic dysfunction, provided hypotension is avoided. Previously I have said that if there is continual hypotension, that will be a problem in myocardial infarction only. In high-risk patients and those with latent or overt ventricular dysfunction, extension of the therapy continues to happen, survival benefit. So it happens in the myocardial infarction, that is the ST segment elevated myocardial infarction, also in the unstable angina or non-ST segment elevated myocardial infarction. They reduces the recurrent myocardial infarction and need for coronary angioplasty. Apart from this, this is used as prophylaxis in high cardiovascular risk subjects and also in diabetic nephropathy. So nephropathy, not only the diabetic nephropathy but also in the non-diabetic nephropathy also. So nephropathy, the kidney function is decreased irrespective of the blood pressure, either there is hypertension or hypotension, uses of the ACE inhibitors. Next, coming to the angiotensin receptor blockers. So they are just blocking the angiotensin receptors directly. The examples are losartan, candesartan, valsartan, telmisartan, olmesartan and irbesartan. So most commonly this losartan is used, telmisartan is used, olmesartan is used. So losartan, telmisartan, olmesartan, these three are most commonly used in our country. What are the difference with the ACE inhibitor? They do not interfere with degradation of the bradykinin and other ACE substrates. So this is the main difference. So there will be no cough, there will be very less incidence of the angioedema. So when there is continuous cough with the ACE inhibitors, we have to replace the ACE inhibitor with the angiotensin receptor blocker. This is very important. Okay. So there is no rise in level or potentiation of the bradykinin substance P. Consequently, ACE inhibitor related cough is rare. They causes more complete inhibition of the angiotensin 1 receptor and some indirect angiotensin 2 receptor. They cause fall in blood pressure in hypertensive patients which lasts for 24 hours. Long term, heart rate remains unchanged, cardiovascular reflexes are not interfered. Again, there is no significant effect on plasma lipid profile, carbohydrate tolerance, insulin sensitivity. Losartan is a competitive antagonist and inverse agonist, both 10,000 times more selective for angiotensin 1 receptor than for 2 receptors, does not block any other receptor or ion channel except thromboxane A2 receptor. That's why they have some platelet anti-aggregatory property. So they causes less thrombus formation. So when we are giving the losartan, if the patient already have atherosclerotic cardiovascular disease, that is the atherosclerosis, there is more chances of the thrombus formation, they will be helpful. Another helpful actions of this losartan is it has a mild probenecid like uricosuric action. That is, they decrease the hyperuricemia. In many of the cases, all these problems are associated with the hyperuricemia, that is the uric acid level is high. Only the losartan among the angiotensin receptor blockers, not the other ARBs, can decrease the uric acid level. So losartan has anti-aggregatory effect, anti-platelet, anti-aggregatory effect, and they have uricosuric actions also. Candesartan has the highest affinity for the angiotensin 1 receptor and produce the largely surmountable antagonism. Details is not required. Telmisartan most commonly used, you can see in your family if there is hypertension, the patient is already taking telmisartan or olmesartan. It does not produce active metabolite, largely excreted unchanged in bile, no dose reduction needed in liver disease. This is the main difference between the telmisartan and olmesartan, otherwise it is more or less similar. Dose reduction, no dose adjustment is needed in liver and kidney disease in olmesartan. So when there is liver disease or kidney disease, we have to decrease the dose of telmisartan, but there is no dose adjustment is needed for olmesartan. Otherwise, more or less similar. Adverse effects, it is very well tolerated. Hypotension, hyperkalemia can happen. Headache, dizziness, weakness can happen. But the important is, again, this is also teratogenic drug, so it should not be given in pregnancy. Fetopatic potentials like ACE inhibitor, not to be administered during pregnancy. So both ACE inhibitor and ARB should not be given in pregnancy. It is used again in the hypertension. Now it is the first line drug along with the ACE inhibitor for the treatment of the hypertension. There is no cough, lower incidence of the angioedema, RAAS and dysgeusia. Again, it is used in congestive heart failure that causes symptomatic relief as well as survival benefit. Long-term morbidity and mortality reduction happens. Myocardial infarctions, again it can be used similar to the ACE inhibitor. Diabetic nephropathy, again like ACE inhibitor, it can be used as renoprotective agent. Lastly, coming to the direct renin inhibitor, it is known as the aliskiren. It is lesser used other than the ACE inhibitor or ARBs. Aliskiren is a non-peptide which binds selectively to the catalytic site of renin and competitively blocks the access of the angiotensinogen to this site. That is, it directly inhibits the renin. While the concentration of the renin in plasma is increased by feedback, since it is blocked, by means of the feedback, renin level is increased, the plasma renin activity is decreased. That is, the activity of the renin is decreased in spite of the increased renin level. Angiotensin 1 and angiotensin levels falls when it is used in the long duration of time. Causes fall in blood pressure, which is more marked in the sodium depleted subjects with high basal plasma renin activity. It is similar to ACE inhibitor. Plasma aldosterone levels are lowered, accompanied by mild natriuresis, that is, sodium level is out, and a tendency to potassium retention. Antihypertensive efficacy is similar to the ACE inhibitor or ARB. Combination can be used when we need more robust decrease of the blood pressure. It reduces hypertensive left ventricular hypertrophy and benefit congestive heart failure patients, but its value as monotherapy or additional drug remains to be determined. That is, the clinical trials are less. It is also renoprotective. At present, this aliskiren is mainly recommended as an alternative antihypertensive drug for those who do not respond or do not tolerate the first line drug, and in combination with others for greater blood pressure lowering. So when there is hypertension, the first line drug is the ACE inhibitor, ARB, diuretics and different other agents. So if it is not controlled, then this aliskiren or direct renin inhibitor can be used. So aliskiren directly inhibits renin, but it is not used nowadays because of different types of the adverse effects. There are maybe dyspepsia, abdominal pain, loose motion, headache and dizziness. Acute hypotension, hyperkalemia, cough and angioedema are less frequent. But the problem is hypotension happens in many of the cases, and aliskiren is also contraindicated during pregnancy. So this is about the aliskiren and different other agents that ultimately acts on the renin-angiotensin-aldosterone mechanism. So thank you. Any question? So within this renin-angiotensin-aldosterone system, what are the physiology of the system, how the renin, angiotensinogen and aldosterone are related to each other, how the angiotensin converting enzyme acts, how the renin is activated, this is important, and the angiotensin converting enzyme inhibitors, what are the names, how it acts, what are the actions of the AC inhibitor, what are the adverse effects. Again, the angiotensin receptor blockers, what are the drugs, how it acts, and what are the adverse effects. And lastly, adiskinin, it is very less used and less asked, but the most common is the AC inhibitor and ARB. Okay, any question? So in the next Friday and Saturday, the class will be on the antihypertensives. So perhaps in the routine there will be an omission on the Friday. So Friday is also antihypertensive.